All right, good morning, everybody. Welcome to Coplow Rounds. Uh, my name is Dr. Jamie Miller. I'm one of the staff pathologists here, and I'm going to get us started with our first couple cases. All right. This first case is from a 9-year-old, they say mixed breed spayed female cat. This is the left eye. And this patient comes with a history of the left eye being ophthalmic with some conjunctival hyperemia. They noted posterior synechia and corneal vascularization and lens opacity on examination. They said that the ventromedial sclera also appeared to protrude. About a week later, things seemed to get worsened. There was complete opacity affecting the eye, and they were not able to see inside the structures. There was periocular swelling and pain on palpation and severe blepharospasm. They said yes to glaucoma, said this had been going on about 6 months, and they decided to enucleate due to inability to continue to medicate this cat. They also attached some additional history to the submission form or submission platform, and what I was able to dig out of there is that this cat did have a traumatic event. She ran into a clear door that resulted in a corneal ulcer about 4 weeks ago. So that was some interesting additional history. So this is our globe. It's a little bit tilted and it's a little bit distorted because this is the cornea here. Very large, bulging forward. This kind of white structure here, this is the third eyelid. And this is the bulging area that they were noting on their gross exam. Here's our iris here. Here's our lens is a little bit subluxated because of this distortion to the globe. The retina is maybe a little bit detached here. And so we're going to look at some of these features. All right, so if we do our subgross view here, let's put it sort of in the orientation that it was on that gross picture. So we've got cornea at the top. We can see some blood vessels coming in here. We can see this thin region here that kind of bulges anteriorly. Here's our third eyelid. And a lot of that thickening in the tissue here was a bunch of edema, a little bit of hemorrhage, but not much going on. The other thing that we can notice here, so here's our iris leaflet here on this side. And this iris leaflet and the ciliary body here are really posteriorly displaced. I think the endodesmase was up here somewhere. And so there's a really large angle recession, as well as the fact that the iris and the ciliary body are lifted up and away from the sclera. And so this is cyclodialysis, which can be a result of trauma. But the other thing to notice here is that there's a lot of, blueness to the iris on the front and on the back, and there's some large clear spaces here that we'll go look at closely because that's also very important for this case. All right. So focus here. All right. So here's our third eyelid. Here is that bulgy area that is a very thin area of the limbal sclera. So it's very thin and it bulges anteriorly. So we got a staphyloma. Got, again, a little bit of vascularization and inflammation coming in here. The cornea is ulcerated. And then if we come back and look at our elevated iris and ciliary body here, we see these clear spaces are actually lined by cells. And these cells also line the anterior and posterior portions of the iris. They are over the ciliary body here. So the ciliary body should have the pigmented epithelium, the non-pigmented epithelium, and then nothing else on top. But there's an extra layer of cells. And if we follow these cells, they continue back here into the choroid, and they also line the anterior portion of the retina, which is also partially detached. We've got some nice little hypertrophy of our RPE cells and some debris underneath the retina here. So if we come look at these cells, So these cells are lining the structures of the eye. They're also forming these acini. They are kind of cuboidal to columnar. Moderate amounts of eosinophilic cytoplasm, round oval nuclei, finely stippled, prominent nucleoli. Got a nice mitotic figure here. Some of them, they are a little bit easier to tell. They maybe have, you know, maybe some secretory material in their cytoplasm. It's a little bit more kind of vacuolated. So this is consistent with metastatic neoplasia. And this carpeting behavior is what kind of defines a metastatic behavior of this neoplastic population rather than a primary intraocular neoplasm. The structures that it's forming lend to it being an epithelial neoplasm. And the primary most common location in cats for metastatic disease is the respiratory tract, so like lung and nasal cavity. Uh, So the neoplastic cells could also be causing the distortion of the angle there in the cyclodialysis. That's also possible. So we've got kind of trauma and neoplastic involvement here. And then some of these kind of neoplastic cells kind of form, they're kind of like right in line with like the rest of the blood vessels here in the choroid. So it's very suspicious that these are probably also maybe lining vascular channels as well, especially given some of the looks at some of these round spaces. Um, so also, one thing in addition to that extra history that I was digging through, this cat also apparently has toe lesions on all four of its feet, discoloration of the middle toes with exudate in the history. So not particularly eye-related, but definitely going on with the body and with the fact that there's intraocular metastatic disease, carcinoma, in this eye, and our most likely primary site is probably the lungs. The lung, if they can confirm that clinically with staging, that they might be looking at feline lung digit syndrome. So thought that was kind of a fun surprise to catch with this case. And it could have run into the door because of eye disease, especially since it said the eye disease seemed to be going on for 6 months, but the trauma was only four weeks ago. So trauma to a blind eye, potentially. So that was that case. Okay. All right. Oops, go back. Okay. Next up, I have another cat. It's an 18-year-old male neutered domestic short-hair cat who presented to the ER for urinary obstruction, but was acutely blind. And so on ophthalmic exam, they said there was a mild subtle lateral strabismus, scleral injection, and conjunctival hyperemia. Cornea was clear, but there's 2+ flare. They noted that the lens iris kind of diaphragm was shifted anteriorly. The pupil was mid-range to miotic with mild rubiosis iridis. Otherwise, the anterior segment seemed normal to them. There was vitreal hemorrhage, and they were unable to really see the rest of the posterior segment. There was negative menace, negative dazzle, and negative PLR, and a slight positive consensual PLR from the left eye. So this is the right eye that we have that's affected. They did say that the left eye did have uveitis and a superficial corneal ulcer as well. So they weren't sure how long this is going on in this cat, but they took this eye. And grossly, we noted when we were examining the eye that the eye was very firm on palpation. We also noted that the optic nerve, the surgical margin of the optic nerve was kind of brown looking instead of a nice kind of like tan. And so there's concern that during the grossing that maybe there was intraocular neoplasm that could be in there. If there's a lot of brown discoloration from like a melanocytic tumor, if it's leaving the globe through the optic nerve, you can get kind of a brown discoloration. This happens to be a picture of the other half of the globe because we don't have the optic nerve here. But what we can see here is that the anterior chamber did seem very narrowed and collapsed. So we have the iris and the lens here, and that's because it's being pushed forward by all of this brown, dark red material. Some of it is a little bit gelatinous looking. There's some tan tissue in here that is probably detached retina. And so we will take a look at what is going on histologically. Here, I can find, oops, leave that in. There we go. All right. All right. So here is our cornea at the top. You can see a little bit of corneal epithelium. There's a little bit of ulceration here because it kind of goes away. Here's our iris leaflets being kind of pushed forward, as is the lens, though the lens is still behind the iris leaflets, so it's still in a normal position there, just being pushed forward. And again, what's pushing it forward is all of this red to pink material. So we have some hemorrhage and some high protein fluid in here. There is some tissue here, some pinkness, and I'll show you a little bit closer that it's detached retina. And then this is why the optic nerve looked brown grossly, because it is filled with abundant hemorrhage. And you can see that there's a little bit of blueness here because it was inked just in case we needed to know margins for this case, but that is not our biggest concern here. All right. So again, cornea, it's got a little bit of an ulceration. Follow it back here. Iris, there's a lot of ectatic blood vessels in the iris and ciliary body. Go over and show this other side too. So they're really ectatic. There's no nefarious cells lining it as there was in the other case. So there's no neoplasia in this case. There's maybe some minor cataract, but the biggest feature here is all of this hemorrhage and eosinophilic material. And then this tissue here is our detached retina, which is very atrophied. And if we follow it along, we start to lose its integrity. And so there's necrosis in here as well. So we have retinal detachment and necrosis. We have abundant intraocular hemorrhage and high protein fluid and edema in the eye, lots of hemorrhage in the optic nerve. And so the big thing that we want to double check is how are our blood vessels doing? And our blood vessels in the choroid, not super happy. So here's one here. We can see that the tunica media is thickened here by smooth muscle cells, as well as eosinophilic material. Let's see if we can, there was one. So like this guy here, it's kind of smudgy walls, and it often narrows the lumen. So we have a vasculopathy here. So here's another good one. And the best one that I found is this guy right here. So it's like, yes. Yeah. So lots of eosinophilic material. We got probably a couple different lumens here, so maybe some recanalization here going on. And so we've got a vasculopathy in the choroid, as well as a bunch of intraocular hemorrhage, retinal detachment, and necrosis. So this is something that we often associate with systemic hypertension. So that was something that was presented in the report for them to go check out. Presumably, they got the cat unobstructed at the ER. There wasn't any inflammation in this globe to offer an explanation for their uveitis and in the other eye, but there was a corneal ulcer, so maybe that had something to do with it too. So it was pretty just a nice, like a hypertensive lesion in a kitty cat. Any question? Just comments. All right, then I will get out of the way for our next presenter.
All right. Hello, this is Gillian. Um, okay, so the first case I have to present is a 3-year-old spayed female Shih Tzu. The history we got was the left eye, which is this one, mucoid discharge, hemorrhagic sclera, moderate exophthalmia, corneal edema, centralized non-healing ulcer, wet/matted adnexal hair in contact with the eye. Ew. Pain, unable to perform a retinal exam. Um, they were not sure whether this eye was glaucomatous. Um, and duration they said was weeks, which is interesting. And then the other eye basically has the same problems, maybe not quite as severe. They say mydriasis, hemorrhagic retina, presumed retinal detachment, and also wet matted adnexal hair in contact with the eye. So this is the second half of the eye. We did not take a picture of the first half, which would have the optic nerve in it. So this is the other half. And basically what we do see in this eye, up here we have the cornea. It's quite opaque, so there's something going on in the cornea. There's a lot of hemorrhage in all of the ocular chambers. There is this white to off yellow or off white to yellow material adhered to the back of the iris and the ciliary body. And then back here, the retina is detached. These are actually fragments of the retina. And there's just more blood there. So those were the more significant findings grossly. Often we don't end up taking pictures of globes that are full of blood because they're kind of boring grossly. But this is not a boring case. As Dr. D says, blood in the eye, sometimes interesting, sometimes not. This one's pretty interesting. All right, I guess we could go down. All right. Mostly what we see is a lot of proteinaceous material in the anterior chamber. The iris is a little bit smudgy and has kind of loss of detail. The lens is pretty boring. And then there's some hemorrhage in the vitreal space and in the subretinal space, and the retina is detached. The optic nerve is a little bit atrophied, and there is hemorrhage in the optic nerve, just like Jamie's case that she just showed. There's also hemorrhage in the peripheral corneal stroma. So those are the main features. So not interesting yet, you say. I agree. All right. Okay. So they said there was a corneal ulcer that was non-healing, and what we do have, at least in this area, is a layer of very attenuated corneal epithelial cells. So probably it was ulcerated, and the corneal epithelium has spread across to cover the corneal surface. There are a few neutrophils in the corneal stroma here, and then as we move peripherally, we can see there's some decent vascular growth into the peripheral corneal stroma, and there's also a lot of hemorrhage associated with those blood vessels, which is a little bit interesting. You don't often see corneal stromal hemorrhage. And then when we move back into the eye, here's the iris, and it is expanded by hemorrhage and a lot of sort of pink shmooey stuff. I'm just going to call it shmooey stuff. There's pink material and red blood cells in the anterior chamber. And we really do have loss of the normal structure of the iris epithelium, which lines the back of the iris. And the iris just looks really abnormal with loss of architecture. As we move back, I'm actually going to zip to the other side here. So we move back into, we're moving into the sort of equatorial region of the globe. This is a vein of the scleral venous plexus, and this should be a relatively thin-walled blood vessel. Well, it's actually a vessel that carries aqueous humor out into the venous system to return it to circulation, and that's how aqueous humor is returned to the circulation. It should never have a wall that is this thick, and we really can't see the lumen of it. And as we move back, there's more of the hemorrhage. As I said, the retina is detached. And we have regions of intraretinal hemorrhage right here and right here. And then back here, the optic nerve is a little bit cavitated, so it is atrophied. And then there's hemorrhage in the optic nerve itself. Sorry, I think I meant to say optic nerve head was atrophied. So we're actually going to move back to the front, return to the front, I should say. And we're going to focus in on the limbal region here, which is where the sclera transitions into the corneal stroma. And we're going to look at the blood vessels in this area because they're really unhappy. And hang on, there's a great one. So what we have is a relatively large blood vessel here, or at least that it is somewhat dilated. And as you follow it around, we can identify the wall here, the tunica media, and we've got the corneal endothelium here. And then as we move around, all of that architecture is just gone. And what we have in its place is these collections of brightly eosinophilic material. And so we have some neutrophils and all of this pink, lighter pink material, and then a bunch of cells. Let's go higher. Uh, so we've got some cells. Some of these are neutrophils. I can't center it. And so what we have here is uh, loss of the corneal endothelium and the tunica media and the layers of the this vascular structure, and replacement with a bunch of fibrin and proteinaceous material and neutrophils, some of which are degenerate. So this is a great example of fibrinoid vascular necrosis and or vasculitis. And as we move around, it's actually a common feature of many of the blood vessels, at least in the conjunctival substantia propria here. And also what you can see is, which I didn't point out at lower mag, is that there's a lot of hemorrhage. All of these brighter pink structures are little red blood cells. So here's another vessel where you really just lose the architecture of the wall altogether. I didn't find the best examples of vascular lesions in the iris, but what we do have, and this is a great area to focus on, we have relatively viable iridoid tissue with blood vessels. You've got some iridoid melanocytes, and then we have this great area of hemorrhage, and then we have just absolute necrosis of the iris. So presumably this is an ischemic vascular necrosis, sorry, the ischemic necrosis of the iris, associated with poor blood supply, so ischemia, as I said, 13 times now. Um, and as we move back into the vein of the scleral venous plexus, which should be, as I said, a relatively thin-walled vessel, and it really shouldn't contain blood, unless there's blood in the anterior chamber, which there is in this case. The wall of this vessel is expanded by sort of disorganized smooth muscle cells. It's hard to identify the endothelium, the vascular endothelium. And then also we have a bunch of neutrophils and a bunch of fibrin. So this vessel is also undergoing some sort of vascular necrosis. Here's another vessel, another vessel. So this is just a repeated theme throughout the eye. And when we look relatively lower mag, this is one of the plica of the ciliary body. It's just completely necrotic, diffusely necrotic there. Same story over here where we have iris necrosis, ciliary body necrosis, presumed all ischemic. The lens actually does have a cataract. I forgot about that. So this is a minor problem for this dog. But there are Morganagian globules here. Well, just happened. There we go. Morganagian globules. So this is a hallmark of lens fiber degeneration or cataractus degeneration. Moving back into the retina, as I pointed out, there's just really extensive retinal necrosis and hemorrhage. So those are the main features of this eye. So let's just skip over to the diagnoses. So fibrinoid vascular necrosis with thrombosis and recanalization of the bulbar conj, scleral venous plexus, and choroidal blood vessels, plus or minus some retinal blood vessels, and idiopathic. So that is the main and most important diagnosis in this case. I did ask a bunch of follow-up questions in my comment and nobody got in touch with us. So I really have no idea what's going on with this dog. It does have bilateral ocular disease, and I would bet that there's vascular problems in the rest of the dog as well. So, and I'm surprised that he even survived this surgery, to be honest. So or she rather. Anyway, so there are many different causes of fibrinoid vascular necrosis. Some of them are infectious, some of them are toxic, and some of them are like cardiovascular specific. They gave very little history. They said nothing about the general health of this patient. So I really have no idea what could possibly be the cause. It is a fairly young dog, 3-year-old Shih Tzu. So I asked if she had any other systemic or biochemical abnormalities, had she been vaccinated recently or received any medications, and has any infectious disease testing been done? So I literally have no idea, but there are many different causes of this vascular lesion. This is something that we see very rarely in the eye, so I was like, whoa, what is going on here? So anyway, I thought that was an interesting case, and if I ever want to try and present this at a meeting, I would try to get more follow-up for this dog. So, any questions, comments? Spectacular, I heard. Yes, that's kind of what I thought. At first I thought, wow, I'm an eye pathologist. I don't know what to do with this. And then I was like, yes, you do, Gillian. It's okay. It's going to be okay. I did show it to one other person and they confirmed my fears that this dog had fibrinoid vascular necrosis. And we talked about how it could be caused by 1,400 different things. So there we go. Anyway, okay, moving on. The next case is a 7-year-old neutered male Siberian Husky. We got very brief history on this one. They say painful, IOP of 71, and hyphema. So we got the globe and we hemisected it, and there was a mass. So we said there was the iris and ciliary body were circumferentially expanded by a tan brown mass. The lens is a little bit cloudy. And once again, this is the second half of this globe, so we did not take a picture of the first half. But when I looked at the slide, I was like, I need a picture of this, much like the last case. Anyway, so here's the other half of the globe, and there was still plenty of that mass to be seen. So you can see it is a tan mass that basically fills and expands the anterior chamber. It has some hemorrhagic areas. This is probably the iris on this side. And what we can, so this is the detached retina. What we can appreciate here is that the choroid on this side is quite pale. So there's very little pigment in the choroid on this side, but there's a decent amount of pigment on this side. So that is an interesting feature of this case. And this is a Siberian Husky, known for having blue eyes. So let's take a peek. Oh, let's do this. Always somewhat dissatisfying because we can't get it all into focus at the same time. Okay, so there's the cornea. There's some vessels in it, so that's the most boring aspect of this case. Here's the mass. You can see that there are islands of more purple areas. Those are viable cells surrounded by pink areas. That's necrosis. So there's multifocal decoalescing necrosis. Probably it's survival around blood vessels. And there's also areas of red blood cell accumulation. So there's some hemorrhage in there as well. The lens is pretty boring in this case. And once again, we do have optic nerve head cupping and atrophy. So there is glaucoma here. Not surprising when you have a mass that's that big, occluding your aqueous humor outflow. Okay, so we're just going to focus mostly on the mass here. So let's just go right here. So from relatively lower power, and as we start to get to higher magnification, we have spindle cells that are sort of haphazardly arranged. Maybe you could convince yourself they're making some bundles and streams. And even at this low mag, you start to pick up some pretty significant atypia. So this is a very large cell. Maybe it's undergoing mitosis. Kind of hard to say. And then right adjacent to it, you can see this is a really big nucleus compared to some of the smaller nuclei around it. There are pretty large, prominent magenta nucleoli. This one has 2 nucleoli in this nucleus. So there's some pretty significant atypia here. And as we wander around, we get to see more. Here's another cell undergoing mitosis. This is a bizarre mitotic figure. Here's one undergoing more typical mitosis. Same with this one. And then, oops, oh gosh, I just bumped it totally out of the way. So there are cells with more than one nucleus. Well, I really did. So there are multinucleated cells here as well. So, these features that I just pointed out are consistent with a mesenchymal neoplasm that's relatively poorly differentiated and has adopted a number of malignant features, including a relatively high mitotic rate, and significant pleomorphism. So cells that are different sizes, nuclei different sizes, multiple nuclei, et cetera, et cetera. Bizarre mitotic figures as well. What I wanted to point out, let's stay at this lowest mag here. So this is the ciliary body on this side of the eye, and it has no pigment in it. As we move back to the choroid on this side, there's no pigment in the choroid. But if we move to the other side, all of a sudden there's pigment. And as we move forward, there's pigment in the ciliary body on this side as well. And then this is the iris leaflet on this side of the globe, which is also pigmented and is also much less affected by the neoplasm. So what we're seeing here is relatively normal iridostroma stromal pigments. So these are melanocytes that are native to this iris stroma. And on this side, the neoplasm is present, but it's actually on the surface of the iris, which I thought was just an interesting feature. So I diagnosed this as a schwannoma, which we typically follow up with schwannoma of the blue-eyed dog, uveal schwannoma of the blue-eyed dog. I found that this was just a really interesting one because it seemed like the tumor originated in the blue part of the iris. The iris is pretty much effaced on this side by the neoplasm, but I assume that it was poorly pigmented over here, much like the ciliary body was poorly pigmented. So I thought that was an interesting feature, and I don't know if it's true that this did originate in the blue part of the iris because I can't really confirm it here. And then just sort of filled the anterior chamber and worked its way onto the surface of the iris on the other side or what. So most uveal schwannomas are benign. Once they're removed with complete margins, they do not recur and they do not metastasize. We do have a few cases that we've learned after the fact, did end up with metastatic disease, but it's extremely rare. This is one, I cautioned the clinician that this one is really ugly, and I suggested maybe a little bit closer follow-up for this patient. So uveal schwannoma with malignant features, heterochromic eye. There was also some necrosis of the iridociliary epithelium, which is probably related to high IOP, and there was a relatively acute glaucoma here. So I don't want to take up too much more time with this case, but I just thought it was a pretty cool one. So any questions, thoughts?
Really?
Dr. Gasper asked where they met. That is a good question. I can't remember. Do you remember?
We had a few regional lymph nodes and lungs, the one that I can remember that we actually published. Yeah, that's all I can say.
So lungs, lymph nodes, in the case that we published, but it is incredibly rare for them to metastasize. For the most part, they're very benign, and you remove the eye and they're good. So that is all I have.
Doing great on time.
Yeah, actually. Now I should have shown more features.
No.
I
I want to see more of the mitoses. They're kind of fun. There's like one that was like multiple like metaphase like formations. Kind of cool.
Well, you can take your time.
That's true. I'm gonna
How pretty that is.
do a boards level description for each of these. Okay. So there's a little bit of a theme for both Jamie and Gillian. They both did an intraocular neoplasm and then like a vascular disease of sorts. I am not abiding by that theme. I have created my own theme. So my first case is, let's see, this one. So this is the globe from a 6-year-old intact male Yorkshire Terrier. The history we got is kind of long to summarize. This is the right eye. It was blind. The fundic exam showed a diffusely anteriorly displaced tapetum. They said the ventral fundus was difficult to view, though there was evidence of serous retinal detachment. They suspected a choroidal mass posterior to the tapetum, and they did an ocular ultrasound that showed a mass lesion originating from the posterior wall, nearly extending to the level of the lens. And they said when they enucleated, there was no overt retrobulbar tumor. They said no to glaucoma, and that is it for the history. So this is the gross hemisection of that globe. We still have a little bit of third eyelid here. Potentially we just kind of left everything intact because there was concern for a neoplasm, so we want to preserve the margins. That's why we have a little bit of adnexus still attached. Cornea is up top, maybe it's a little bit cloudy. Here's our lens right here, which we had also noted was maybe a little bit cloudy as well, so maybe some cataractus degeneration. Our uveal tract actually looks pretty good. So here's the iris. We have our choroid, and we can kind of follow it. It still looks pretty discrete, and maybe there's areas where it looks a little bit thickened subjectively, but there's no kind of overt neoplasm associated with the uveal tract. Vitreous, quite cloudy, it's a little bit hard to see. Maybe here's our retina right here. So it does look like there is some retinal detachment and a similar cloudy material in the subretinal space. And then there's just kind of this non-discrete thickening of the sclera and episcleral connective tissue. So we can kind of see this really crisp white line is our sclera, and it becomes a little indistinct right here. And then there's just kind of this vague mass effect, which is also associated with this area of retinal detachment. Okay. Let's move to the slide, which I have ready. I kind of just want to put it right on for the element of surprise. I have to like dance around though. Okay, there we go. Nope, it's already full screen. Okay. All right, so our cornea is to the right, posterior segment is going to be to the left. And there's really not much going on with the anterior segment. This cornea looks rather immaculate. There are a few vessels in the periphery, which isn't very specific for anything or very exciting in this case. Here's that little snippet of third eyelid. Maybe we have a titch of cartilage just coming into view. And there is just a little bit of inflammation associated with our third eyelid conjunctiva. Also nothing terribly exciting. Just a lymphoplasmacytic infiltrate. Here's some plasma cells. And then we have these lymphocytes that are making this little follicle with a little germinal center. Just chronic inflammation. As we move this way, there is a uveitis. A little bit closer to show that. So within our iris stroma, we have some lymphocytes and plasma cells. Pretty intense uveitis. And there are some neutrophils also hanging out in the anterior chamber. And you can see more of that uveitis. As we move back, just more lymphocytes and plasma cells. Got one for the effect. Oh!
That's the right range.
So as we move back to our posterior sclera, episcleral connective tissue, this mass effect actually is not neoplastic, which is good news. It's an inflammatory mass. So these are inflammatory cells, all of these kind of purple dip dots, and they're all surrounding these cross sections and kind of sagittal sections of a nematode parasite. Here's a nice sagittal section. And to show the extent of it, rather intense. And I will zoom in to show the features of that parasite. While I'm on low power, just quickly show that there is indeed a retinal detachment. And we do have a lot of this proteinaceous material kind of lifting that retina up. So that does fit with the clinical diagnosis of a serous retinal detachment. And there's more inflammation within our choroid too. And as we move over here, it's more of that kind of proteinaceous material. And there's just some inflammation kind of here and there, a little less intense where we're not seeing those parasites. Okay, let's actually look at them. I dotted one area, but I think there's some other features I wanted to show first. I should have put some other dots in. Let's see. They're so cute. They're really cute. I feel like they look like faces sometimes, like this little guy's got like glasses and he's really surprised. I think they're really cute. Okay, let's just land here maybe. Oh, nope. I bumped it too. There we go. Maybe go one closer even. Haha, really close. All right, so this is a nematode parasite. It has a few defining features that help us say who this guy is. So like any nematode, it does have an eosinophilic cuticle. This one in areas it's a little more smooth, but we also have these little cuticular ridges or annulations. You can see those little bumps on its cuticle. Um, its musculature technically is coelomyarian polymyarian, which means that it which honestly I never know what these musculatures mean. Usually with that kind of a musculature, we kind of see like very prominent bands of muscles. In this particular parasite, it tends to have like a more low profile, looks a little more atrophied, and they also have kind of a thick hypodermis. It has a pseudocoelom, so all this clear space. And then within that pseudocoelom, there is evidence of a GI tract or intestinal tract, as well as a repro structure. So this is probably uterus. And as we move around, let's see, where'd my dot go? Here's my dot. There's some other structures within that reproductive tract. Dun, dun, dun. So cute.
Babies.
Babies. So within this uterus, we have these little, I guess, I don't know, linear structures. Sometimes people call them like a bag of nuclei. You can kind of see these little like dip dots within them. These are microfilaria. So this is a filarial nematode. So not to beat around the bush anymore, but a filarial nematode, when we have it within this location in a dog, so kind of sclera, episclera, this is going to be most consistent with onchocerca. And if we kind of look outside of the adult nematodes, there's also some free microfilaria within the sclera, which is kind of fun. Yeah, they're free.
You guys. You're in those.
Oh, like right here. Yeah, you're right. That's nice. There we go.
Great.
This shows it way better. You're right. Yeah, we have slightly better, kind of more prominent polymyarian, coelomyarian musculature.
These guys are live.
Yeah, these guys are very viable looking. And in some cases, yeah, we kind of just see necrotic parasites, and sometimes it's just parasites that are kind of embedded in fibrous tissue. This is a rather robust inflammatory reaction. I wonder if it's because there's free microfilaria in here as well. But either way, yeah, it's enough to create a pretty intense mass effect. Kind of a cool one. I think over on this side, yeah, there's a couple of dead guys. Didn't quite make the voyage. They still have some features though. They're just maybe looking a little less happy. This guy's a very sad.
I like their description of the imaging and how it relates to the kind of an intrascleral nature of this, which is
Yeah.
odd. Probably extended into the sclera. It started probably as an episcleral lesion, but the effacement of the sclera itself. And the fact that they did recognize, right, it was like,
Yeah, I really like the
Scleral
progression of how
structure.
they saw it too, like
Yeah.
off like fundoscopic exam and ultrasound, just kind of localizing where this was. Kind of a little bit of a journey in the
Yeah.
history.
so we love ocular pathology. And ophthalmologists like ocular pathology too, because it's a pretty good direct correlation with what they see and what we see.
Yeah, nice one. So that's our main finding. I'll go a little closer just to quickly show our choroid and retina, but figure kind of our intraocular lesions are likely due to what's happening in the sclera episclera. So there's just more lymphoplasmacytic choroiditis. It's the inflammation's most intense in the choroid, but also is present throughout the whole uveal tract. So we have a panuveitis. And then our retina is detached. There's a little bit of lymphoplasmacytic inflammation as well. And as we see from our chronic retinal detachments, we'll start to see atrophy of the outer nuclear layer. In this case, it looks like just the inner and outer photoreceptor segments, or what we call the frilly frills, are absent. So evidence of chronic retinal detachment. Yeah, I think as we move out, yeah, it's mostly just kind of that outer layer. All right. And those are our main findings.
Where's stocks from?
That is a great question. So this dog is from Washington State, which is interesting. Yeah. As I say it.
Native, yeah.
Yeah, like a native Eastern Washingtonian. So the question is, yeah, where this dog was from. So Washington State is kind of interesting because this does have a somewhat specific geographic distribution. So within the United States, it's typically more of our southwestern states that we see this. So I did query in the comments if this dog did have any travel history outside Washington, and I never heard back. So it is unclear. And this isn't just localized to the United States. I think last time I showed an onchocerca case, we had a lot of people chime in about other places that they've documented it. So like Mediterranean countries, European countries also have a preponderance of onchocerca, and probably some other countries that I'm unaware of. But yeah, it is somewhat localized within the US. So it is kind of interesting that it's not from the Southwest as far as we know. Other things about onchocerca, so this is a vector-borne disease. That's probably why it has a more specific geographic distribution. And typically, we do see in like the sclera, episcleral tissue, we can see in the orbital tissues, the conjunctiva. That's going to be most common. So oftentimes we'll have a history of there being like a conjunctival or like episcleral nodule. And sometimes grossly, we can even see like the little worms within the nodule if you're looking very, very closely. I think in our gross photo, it wasn't super obvious. It just kind of looks like a vague mass. Cool. So that is my first case. Any questions, concerns, thoughts? If not, I will go to my next one. This one, I do not have a gross photo, tragically, but we do have a nice clinical photo from the clinician, which I appreciate. So this next case is going to be a 4-year-old female spayed Labrador retriever. And it sounds like from the history, the primary DVM had concerns for an intraocular mass. Under our ophthalmic findings, they said that this eye was blind, there was rubeosis iridis, and then they said anterior lens capsule pigmentation. And they said no to glaucoma. And already we can see like maybe there's like a smattering of pigment and there's kind of just this like wispy tan material. I admit I'm not an ophthalmologist, so that's as far as my description will go for you all. You can look at this beautiful photo, and I will paint you a word picture from our gross findings. So we said the globe did look a little bit ophthalmic. We had said that there was tan brown stuff on the choroid, and there was exudate/pus in the vitreous, and the retina was detached. So move to. One more. Okay. This one I can actually do a subgroups, maybe. Okay. So cornea is going to be up top. You can kind of ignore this little thing. I don't know what that is. Little foreign object. So there is a uveitis. It's just a little bit busier within the anterior uveal tract. Our lens isn't particularly exciting. As we move back, our retina is indeed detached.
And exciting.
And exciting, much more exciting. That's my theme, exciting posterior segments. And our retina, it looks like there's just like a little bit more happening with it. There's kind of these globs of stuff, for lack of a better word. Maybe I should say shmoo as well. On the kind of subretinal surface, maybe within the vitreous as well. As we go back, our choroid also just looks a little bit more cellular, like there's some sort of infiltrate. And there is also, I think grossly we'd said stuff, tan brown stuff on choroid. So I imagine that's what this is. We can see this material on the choroid that looks a little bit cellular as well. You can ignore my Sharpie mark. That will come into play later. Okay. Focus. Am I focusing the right way? There we go. One day. There we go. Okay. So cornea again, to the right, posterior segment to the left. Similarly, this cornea is not very exciting. We have some vessels at the periphery, which, as we've seen in almost every case, it's a pretty common finding. We have some pertinacious material in the anterior chamber. There's maybe a little kind of membrane that's coming off the anterior surface of the iris, maybe heading into the pupillary space. A little bit closer, just a little reactive membrane. And looking within our iris, some kind of non-specific lymphoplasmacytic inflammation. We do have some endothelial hypertrophy, so endothelium is activated by something happening. And maybe as we go a little closer, we can see that little membrane does have some maybe vessels associated with it. There's also a lot of inflammation within it. So just a reactive fibrovascular membrane, which is also not terribly specific. We see it with a lot of stuff. Here's a better fibrovascular membrane, which I realize is not the most important thing. I don't know why I'm really showing these in such detail, but little fibrovascular membrane, just because I have time. You guys get to see it all. And it is causing this kind of very mild kind of outward displacement of the iris margin. So this is ectropy on uvea. As we move back, here is our detached retina. You can see kind of that material in the subretinal space, as well as maybe in the vitreous as well. But we're gonna just go straight to the choroid. Boom. Okay, so our choroid also inflamed. It's lymphocytes and plasma cells. It's a much more intense inflammation in the choroid versus the anterior uveal tract. And then lining the epichoroidal surface, we have lots of organisms. Trying to find an area where I can make them look a little more distinct. So this guy here, this one here, this right here, these are all infectious organisms. Sometimes they kind of just look like this empty refractile shell. In some cases, they contain this basophilic kind of globular material. Let's see if I can find some more defining features of these ones. Haha. So this right here. So a defining feature of this particular infectious organism is that it does perform endosporulation. So the parent cell is going to undergo internal division, creating a sporangium that contains sporangiospores. And oftentimes it kind of has this tripartite appearance. It looks like a Mercedes-Benz symbol, kind of. And this is kind of what we're looking for when we're trying to find the defining feature for this particular guy. So this feature, as well as kind of the size morphology of these organisms, are all consistent with an algal infection, specifically Prototheca. And as I move around, can just show more of these ones. And sometimes it looks like they're within macrophages, actually.
Yeah.
Oftentimes, we don't really see a very robust inflammation associated with them. We just see a ton of organisms with pretty minimal inflammation, but it's pretty inflamed in the case. Yeah, so here's more of that endosporulation. I can move over to our retina, because that's also pretty spectacular. Dun-dun-dun. Probably should have started here, actually. There's way more. So here are more of our Prototheca organisms, just a ton of them. So these ones kind of look more like, yeah, those empty kind of shells or ghosts of an organism. And as we move around into the retina itself, it looks like they're actually within the retina too. Just kind of show the extent of them. Just a ton of them. Here's more of them. But they are all over the place. And in this particular case too, we have retinal detachment and our optic nerve head is rather distorted. So we can't really say if there was glaucoma in this particular case. In this one, they said clinically they didn't diagnose glaucoma. So not really a particular concern for this one. And those are the main features. So I will switch over to our diagnoses. So yeah, this was a case of ocular protothecosis. Which sounds like maybe that was a surprise for the clinician just based off of the history. It sounds like there was concerns for an intraocular mass and not necessarily concern for an infectious etiology. So this is a pretty, I guess, tragic diagnosis. Most cases have a poor prognosis. Prototheca is quite hard to treat. Usually it's some variation or combination of antifungal agents that are used, and they have variable efficacy amongst individual infections, but a lot of them tend to not do well long term. And Prototheca, so the suspected pathogenesis for it is that dogs will consume the organisms through like groundwater or something like that, infected groundwater. And it tends to penetrate the colonic mucosa. So on the first clinical sign seen usually is a large bowel diarrhea that's often hemorrhagic. In some individuals, it can go systemic, so it disseminates to various organs, and the eye is a really classic place for it to land. But it can go other places like the CNS, the heart, or other really common places. I think the kidney as well is another common one. So in a lot of these cases, they come with a history of having large bowel diarrhea, and then we diagnose Prototheca in the eye. Trying to think if I have anything else to say about Prototheca.
Dr. D is asking.
Yes.
there was any GI disease, but it doesn't seem like there's a lot of the.
So it wasn't offered in the history provided to us, but they did send us the clinical notes for this case, and it looks like the dog was on metronidazole.
Okay.
So I wonder if it did have diarrhea. Yeah. Which is tricky, right? So large bowel diarrhea is somewhat common in dogs, especially ones that get a little bit stressed from time to time. So
It's not uncommon for us to get a case like this where there's not a lot of good history when we receive, but between submission, processing, and reporting, they will call in and ask for a stat result because the dog is not doing well.
yeah.
You know, but in other cases, the disease can be very chronic. We had a few that had impressive long-term clinical signs of, you know, like months and months of diarrhea. And we're like, wow, it's impressive that the dog is still alive, to the point that someone elected to do an enucleation surgery, right? But yeah, bad prognosis.
Yeah, unfortunately. All right. And that's all I got. Any other questions in the chat or in the room? All right. Well, in that case, that is the end of rounds. Thank you all for joining in person and online, and we'll see you in 2 weeks.
Thank you.
I can remember how to do this.
Wow, who's that young guy up there?